And just like if a pregnancy is in the fallopian tube and your doctor's telling you it's an ectopic pregnancy, that pregnancy is also not going to move on its own, and we also can't move them. And this goes back to why we say that an ectopic pregnancy is not a viable pregnancy.
So this would be a good segue into talking about how ectopic pregnancies are diagnosed exactly. And the diagnosis is a combination of clinical evaluation, like we talked about symptoms or no symptoms, imaging, and sometimes laboratory tests like an ACG level.
Welcome to My Fertility Podcast, Superhumans, the show that brings you expert insights, personal stories, and the latest in fertility care all in one place.
Whether you're starting your fertility journey, navigating challenges, or just exploring your options, we're here to empower you with knowledge, support, and hope.
Join us as we dive deep into topics that matter most, from IVF and fertility treatments to mental health and wellness.
I'm Dr. Mavis Garcia.
And I'm Dr. Wise. We're two of the fertility specialists at Markham Fertility Centre in Markham, Ontario, Canada. Think of us as your sisters in all things fertility. Let's demystify the world of fertility together.
Welcome back to My Fertility Podcast. Hello, superhumans. Today, we are tackling a topic that is not only medically significant, but also deeply personal, and that is ectopic pregnancy. While this condition affects only 1 to 2% of all pregnancy, its impact extends far beyond statistics. For those that have experienced an ectopic pregnancy, after infertility, the fear, the heartbreak can be really overwhelming. So, our goal today is to provide clarity, support, reassurance. We want you to understand the causes, the risks, the treatments, all the options, all while giving you space and supporting you and acknowledging the emotional toll that it takes.
Very well said, Dr. Garcia. An ectopic pregnancy is a pregnancy, so when an egg is fertilized, but it implants outside the uterus, most commonly in the fallopian tube. Unfortunately, these pregnancies are not viable. Now, I'm going to say that one more time because there's a lot of debate about this in the current world in certain areas of the world. But an ectopic pregnancy is not a viable pregnancy, meaning that it's not a pregnancy that's going to yield a healthy baby at the end. Another thing is that ectopic pregnancies pose significant health risks to the person carrying the pregnancy. Today, we're going to cover everything you need to know. What causes ectopics, how we diagnose them, different treatment options, and how an ectopic pregnancy can affect or impact future fertility. We're also going to discuss some of the recent research on pregnancy rates after an ectopic and success rates of different treatments.
All right, so let's start with the basics. What exactly is an ectopic pregnancy? Well, after fertilization, the embryo has to travel down the fallopian tube and implant in the lining of the uterus, where it grows into a pregnancy. In an ectopic pregnancy, however, the embryo implants outside the uterus. In about 90 to 95% of ectopic pregnancies, this place outside of the uterus happens to be the fallopian tube, which is why very often you will hear the term tubal pregnancy. But an ectopic pregnancy can occur anywhere. It can occur in the ovary, in the cervix, in the abdominal cavity, or even in a previous cesarean section scar, although that is a lot less frequent.
And the big problem, of course, is that none of these locations can support a growing pregnancy, right?
Yeah, exactly. For example, the fallopian tube is narrow and it's not designed to expand like the uterus. So, as the pregnancy grows, it can cause rupture of the tube, which can lead to severe internal bleeding, which becomes a medical emergency. And that goes to what you mentioned, how it can be really life-threatening for the person carrying the pregnancy.
Absolutely. And so this is why ectopic pregnancies are one of the leading causes of maternal death in early pregnancy when they're not treated. In fact, there was a study published in the American Journal of Obstetrics and Gynecology that found that about 10 to 15% of pregnancy-related deaths in the first trimester are due to ectopic pregnancy complications.
And this is why early detection is key and access to qualified healthcare professional is very important and life-saving.
Before we dive into some of the risk factors for an ectopic, I think it's really important to understand how common ectopic pregnancies really are. We've mentioned that it affects about 1 to 2% of all pregnancies, but let's take a closer look at some of the research.
One of the most comprehensive studies that was conducted on this topic was actually done in Ontario, Canada. And it was a study titled Prevalence and Geographic Variability of Ectopic Pregnancies in Ontario using inpatient and outpatient data. And this was a study that was done over a 12-year surveillance study looking at emergency room visits. This study was published in 2016 and it included 12 years of data from 2002 to 2014 from both inpatients and outpatient sources.
Wow, that's a really long study period. I mean, there are not many studies out there that cover such a long time period. So this can really provide us with a lot of valuable insights.
Yes, absolutely. The study found that the incidence of ectopic pregnancy increased from 20 per 1,000 reported pregnancies in 2022 to 27 per 1,000 pregnancies in 2014. What is really interesting is that when hospitalized data was analyzed, that means the number of patients that were actually admitted, rates actually appeared to decrease from 12 per 1,000 pregnancies to 9 per 1,000 pregnancies in the same period. What this tells us is that previous reports may have underestimated the true prevalence of ectopic pregnancy because they were only looking at hospital admissions, and not every ectopic pregnancy needs to be admitted to hospital, which we're going to talk about later in the episode.
Yeah, and that's really important because many cases of ectopic pregnancies, the vast majority, I would say, are being managed in outpatient settings. And so when that data isn't getting included in studies, we might think that ectopic pregnancy rates are actually declining, when in reality, it seems like they're increasing.
And the study that we're talking about also found a significant geographic variability across different health units in Ontario. For example, the median incidence rate of ectopic pregnancy in Ontario was from 14 to 37 per 1,000 pregnancies. But in some specific public health units, the rates were as high as 55 per 1,000 pregnancies. This highlights the potential disparities in access to care, access to early diagnosis, and reproductive health resources in different health units across the province.
That's actually really huge variation. Did the authors have any theories in terms of what could be contributing to these differences?
Yeah, the study looked at different potential risk factors that could be influence this variability in numbers. For example, some geographic areas have higher risk of pelvic infections. We know that chlamydia can damage fallopian tubes and increase the risk of ectopic pregnancies. Also, the access to assisted reproductive technologies, as well as having prior tubal surgeries. And now it also emphasized the importance of improving surveillance and reporting system to better understand. Because if you're really able to say that there is a specific geographic area with a specific risk factor, then that data can be really used to drive educational programs and early access programs to decrease those rates.
This study is a really great reminder that we need to ensure that all individuals have access to timely reproductive health care and that we continue monitoring trends in women's health and in ectopic pregnancies to help improve outcomes. So, now that we have an understanding of how common ectopic pregnancies are, let's move on to the risk factors. Who's at higher risk and why?
There are several key factors that increase the likelihood of an ectopic pregnancy. For example, a history of pelvic infection like chlamydia and gonorrhea or anything that will lead to pelvic inflammatory disease, which can cause scarring in the fallopian tubes. Also, a prior ectopic pregnancy. So, if you've had an ectopic pregnancy before, your risk increases to about 10 to 25% in future pregnancies. Having had prior fallopian tube surgery would increase the risk of ectopic pregnancy. This would be, for example, somebody that had tubal sterilization procedure done and then a repair. Also, a history of endometriosis can cause scarring of the fallopian tube and lead to ectopic pregnancies. Also, the use of ART or artificial reproductive technologies. Interestingly, even though IVF is meant to bypass the fallopian tubes, there is still a risk of ectopic pregnancies in IVF, which is about 2 to 5% of all IVF pregnancies.
Now, let's talk about smoking, which is one of the most modifiable risk factors for ectopic pregnancy. There was a key study that looked at this in some detail. The study was called Risk Factors for Ectopic Pregnancy, a Comprehensive Analysis, and it was published in the American Journal of Epidemiology in 2003. This study analyzed data from the Women's Health Study, which is a very large US population based case control study that has yielded lots of research in women's health. In this particular study, they found that current smokers had a significantly increased risk of ectopic pregnancy compared to non smokers.
And how much smoking increased the risk in that study?
In the study, they found that the odds ratio for an ectopic pregnancy in smokers ranged from 1.7 to 3.9, depending on the number of cigarettes smoked per day. There was also a very clear dose response relationship, meaning that if somebody was smoking, let's say, less than 10 cigarettes a day, their chance of ectopic was about 1.5 times the general population. If they were smoking more, let's say about 10 to 19 cigarettes per day, the risk went up to about 2.3 times the risk in the general population. Now, if someone smokes over 20 cigarettes a day, the risk of an ectopic pregnancy was about 3.9, almost 4 times that of the general population. So really, we can kind of say from this study that the more someone is currently smoking, the higher the risk of them having an ectopic pregnancy.
Wow, that is a staggering increase in risk. Did the study talk about why smoking has such an impact on the risk of ectopic pregnancies?
It did. So we know that smoking affects fallopian tube function by impairing ciliary activity and smooth muscle contractions. Cilia are like these little hair that are inside the fallopian tube that help kind of brush along a pregnancy, let's say, or that embryo that moves along the fallopian tube. And the fallopian tubes also have these contractions of muscles, sort of similar to, let's say, the bowel, where we see kind of pushing along the food, the bolus that's in our intestines. And so smoking, we know, affects the function of these little hairs or these cilia and smooth muscle contractions in the fallopian tube, also in other areas of the body. And so these things are super essential for moving the fertilized egg towards the uterus. Smoking also increases levels of certain proteins like ProKR1. And again, that may also contribute to tubal implantation instead of uterine implantation.
In episode 6 and episode 7 of My Fertility Podcast, we did a deep dive into the impact of smoking in fertility in general for both people who carry eggs and for people who produce sperm. But we're now learning that smoking can directly increase the risk of ectopic pregnancies as well.
Exactly. The study even estimated that smoking actually accounts for a significant proportion of ectopic pregnancies in the population, making smoking one of the most preventable risk factors for ectopics. And so public health efforts to reduce smoking among women in reproductive age could have a huge impact, actually, on reducing ectopic pregnancy rates.
And once again, I mean, you and I do fertility care, we do fertility treatments, IUI, IVF, embryo transfers, PGT, but we are always talking about lifestyle, right? It is so important to consider lifestyle factors when you're thinking about reproductive health. That has to be the foundation of everything. And then the treatments go on top of that. But treatments aren't necessarily meant to replace the importance of lifestyle factors on reproductive outcomes.
Absolutely. So well said. We've covered some of the risk factors. Let's talk about how ectopic pregnancies actually present clinically, meaning that if somebody has an ectopic pregnancy, how might they know or how might we suspect something as fertility physicians? What symptoms should somebody be aware of?
Yes, this is an important discussion. And if you haven't been paying attention until now, pay attention because this is really important. Ectopic pregnancies don't always present with clear symptoms. Sometimes there's no symptoms at all. And that's why early pregnancy ultrasounds are essential. That is why communicating with your care team that you had a history of ectopic pregnancy in the past or that you have other risk factors is so important, because when we know that you had risk factors for ectopic pregnancy, then we're going to recommend early ultrasounds to make sure that we know that the embryo has implanted in the right place. Even if the early ultrasound still doesn't give you all the information that we want about the pregnancy, it can at least tell us where the pregnancy is located.
That's one of the really interesting things is that we can diagnose ectopic sometimes just based on these routine ultrasounds when people aren't having symptoms. But when symptoms do occur, there are some that are considered very common or, classic. These are the ones you're always going to see in the medical school textbook. It's important to emphasize that not everybody is going to have all of the symptoms. And that if you have these symptoms, it does not necessarily mean that you have an ectopic pregnancy, right?
Yes, absolutely. Some of the symptoms, I should say, some of the classic signs or symptoms of an ectopic pregnancy would be something like abnormal vaginal bleeding, which, again, like Dr. White said, this is very common in early pregnancy. It doesn't mean that you have an ectopic pregnancy, but sometimes can be associated with an ectopic pregnancy. As well, pelvic or abdominal pain, in particular shoulder pain, because when there is internal bleeding, this can irritate the diaphragm. And the diaphragm irritation can cause what is called refer pain to the shoulder. Also, if there is significant internal bleeding, you might have dizziness, fainting, weakness. And also, some women can report gastrointestinal symptoms such as nausea, bloating, and discomfort because, again, the impact of abdominal bleeding in the bowels.
So that's really interesting that these signs are not specific and they can mean lots of different things. So, again, if you're experiencing them, it does not mean that you have an ectopic. But if you are experiencing them, it is really important to let your care team know so that we can then do those next steps to try and figure out what is going on.
And like I said, even if you don't have symptoms or are practice, if you had a prior history of ectopic pregnancy, then we will do an early ultrasound to determine the location of the pregnancy. And then we'll follow up later with the viability ultrasound. But establishing the location early on is important in a setting of a prior ectopic pregnancy.
Yeah, because it's important to point out that pregnancies don't move around. If the pregnancy is in the uterus and we've confirmed that it's present in the uterus, it can't move. It's not going to go back to the fallopian tube.
Right.
And just like if a pregnancy is in the fallopian tube and your doctor's telling you it's an ectopic pregnancy, that pregnancy is also not going to move on its own. And we also can't move them. And this goes back to why we say that an ectopic pregnancy is not a viable pregnancy.
So this would be a good segue into talking about how ectopic pregnancies are diagnosed exactly. And the diagnosis is a combination of clinical evaluation, like we talked about symptoms or no symptoms, imaging, and sometimes laboratory tests like an ACG level.
Let's talk about these different tests here. The very first test that we're going to think about is doing a pregnancy test to confirm that there's a pregnancy. And the way that we do that is with the quantitative beta human chorionic gonadotropin hormone test, or the beta HCG blood test. This is so crucial when we're trying to diagnose pregnancy and trying to differentiate from ectopic pregnancy or miscarriage. In a healthy pregnancy, in a viable pregnancy, that beta HCG level is going to increase every 48 hours by somewhere at minimum 35 to 60%. If the levels are rising too slowly, or if they plateau, or if there is, let's say, a decrease and then an increase, for instance, these are red flags for an abnormal pregnancy. Now, that does not mean that you have an ectopic pregnancy, but it does mean that there's something going on, something worrisome. And ectopic pregnancy is in the differential diagnosis. Studies show that beta HCG levels, when they're above 1,000 to 2,000, we should be able to see something on ultrasound. Not necessarily a heartbeat, but we should be able to see some sort of pregnancy structures on ultrasound. In studies where that beta is in that range, but we're not seeing anything inside the uterus, especially with a transvaginal ultrasound, meaning ultrasound probe or ultrasound camera in the vagina, that's another strong suggestion that this could be an ectopic pregnancy.
Transvaginal ultrasounds, like Dr. Weiss mentioned, is the gold standard for imaging, and it can tell us if there is a gestational sac in the uterus or not. It can tell us if there is an adnexal mass. Like I mentioned, most ectopics happen in the fallopian tube, so you could see that. It can also say if there is fluid in the pelvic cavity, which could be a sign of rupture ectopic pregnancy. According to a study published in the Canadian Medical Association Journal, transvaginal ultrasounds can diagnose about 75% of ectopic pregnancies during the initial scan. And it's even more accurate when you combine it with ACG level testing. So we want to look at both things together with clinical symptoms.
I think it's also worth mentioning at this point that there is sometimes a bit of a gray zone when it comes to diagnosing ectopic pregnancies. I can think of lots of different cases where patients may have had previous ectopics, or maybe we're looking a little bit earlier because the patient has had maybe some spotting, maybe some abdominal pain. And there can be this gray zone where we know that a person's pregnant because that beta HCG is positive, but we just don't know, or we're not sure yet whether this is going to be a viable pregnancy, whether this is an ectopic pregnancy, or whether this is going to be a miscarriage. These tests are super important, but it's important to point out that very often we end up having to repeat them
Yes.
or follow them or track them for a little bit of time so that we can be super, super sure of what the actual diagnosis is so that we can provide the proper treatment. It's terrible. It's awful, this gray zone of pregnancy where
Mhm.
someone is, I don't know, a little bit pregnant. And I can imagine that people are on pins and needles the whole time.
Mhm.
And I wish that we could figure out a way to know right away, but unfortunately, we just don't have the technology available. Although we can do these things, it's not always super clear.
Yeah, I think we all hate it. Physicians hate it. Patients absolutely hate it because you describe it perfectly. It's like this in between zone of hell where you don't know, pregnant, but like, what does it really mean? And then, of
The
course,
pregnancy purgatory.
yeah, exactly. And then you're counseling the patients that this could be an ectopic, and these are all
Yeah.
the things that could happen if it is an ectopic, which of course is terrifying, right?
Yeah.
So yes, it's really hard, but this is why it's really important to have really good communication and really good trust in your care team, because the last thing that we want is to overdiagnose, like tell you that you have an ectopic when you don't, because the treatments, which we're going to talk about in a little bit, are very different from an ectopic pregnancy to a pregnancy that is a miscarriage. So
Mhm.
getting the right diagnosis is important, and also for you to understand like risk factors going forward and things like that. So yes, you're absolutely right. Sometimes it's just not easy to make a diagnosis right off the bat, and you can only look at the trend of the ACG level, the trend of ultrasounds in order to be able to make a proper diagnosis.
And I think it's also worth noting at this point that when somebody is in that gray zone, in the pregnancy purgatory, which I'm going to call it from now on, we are, as a medical physician, you're trained to think about, okay, what is the most common thing that could be going on? But then what is the worst case scenario thing that could be going on? Because you want to counsel the patient about what are the red flags, like what should they watch for, and so that they understand what the potential risk could be, even if it's something rare. For many patients who are in this situation, we might say, okay, well, it could be this, it could be that. If this happens, go to emerge. If that happens, do this, et cetera, et cetera. And we're not doing it because we're trying to scare patients. And even though I think I mention or I counsel about ectopic pregnancies like 10 times more often than I'm diagnosing ectopic pregnancy.
Yes.
Probably even more than that, actually, maybe like
Yeah.
20 times. Because I always want patients to understand that there is this risk of ectopic and that if these things are happening, then they need to go to the hospital, they need to go to the
Right.
emergency room. But the actual relative risk, I mean, the relative risk of a miscarriage is, 15 to 20% of pregnancies. Ectopic risk is about 1 to 2% of pregnancy. And
Right.
again, this is very general numbers, general population. But we'll definitely talk a lot about ectopics more so than how often they actually happen. Not because we're trying to scare people, but just because we want people to understand what could potentially be happening, what those red flags are, to make sure they actually get proper medical care.
Absolutely. So once an ectopic is diagnosed, let's talk about the treatment options now. There are three main approaches to treat an ectopic pregnancy. You can treat an ectopic pregnancy through what we call medical management, which we're going to talk about more. We can do a surgical treatment, or we can do what is called a spectrum management. So we're going to go into detail in each of these options.
Let's start with medical management. Medical management, basically, we're talking about using a medication, specifically a medication called methotrexate. Methotrexate is kind of traditionally known as a chemotherapy medication. It is a folic acid antagonist. It basically will stop the growth of rapidly dividing cells through the body. You can imagine why this is super helpful as a chemotherapy drug. Methotrexate can only be used when the ectopic pregnancy is not ruptured. Ideally, also, you want the beta HCG levels to be below 5,000, and we want there to be no cardiac activity, so no heartbeat for the pregnancy itself. Again, if you're doing it when the beta is higher or if there is a heartbeat present, then the chance of methotrexate working really drops. It's a lot less likely to work. A 2022 study showed that methotrexate had a success rate of about 56% when a single dose of the medication was given, and about 94% with a second dose of the medication, based on how that beta HCG, how that pregnancy hormone drops between days 4 to 7 after giving the methotrexate. Methotrexate has some big benefits as a treatment, and it involves preserving the fallopian tube where the pregnancy is located and avoiding surgery. However, if a patient is going to pursue methotrexate treatment, they really do require close follow-up with frequent blood work to make sure that those pregnancy hormone levels drop to 0, and that can take several weeks.
That was a great summary of medical treatment, Dr. Wise. Now I'm going to talk about surgical treatment of ectopic pregnancy. Surgery is necessary in approximately 40% of cases, specifically if there is a rupture of the ectopic pregnancy or if methotrexate has failed in the past, or if the ectopic pregnancy does not qualify for medical treatment, such as, for example, an ectopic pregnancy that has a fetal cardiac activity present. In terms of surgery, there are two main options for surgery. There is what is called laparoscopic salpingostomy. That means removing the ectopic tissue out of the fallopian tube while preserving the fallopian tube. Or you can also do a laparoscopic salpingectomy, which means removing the affected tube completely at the time that you're removing the ectopic pregnancy. The decision to do a salpingostomy, which means leaving the fallopian tube and just removing the ectopic, versus a salpingectomy, which means removing the affected tube, really depends on a number of factors. For example, the history of prior ectopic pregnancies. If somebody had had multiple ectopic pregnancies in the past in the same fallopian tube, this would be a really good indication to remove that tube because it clearly is not able to pass an embryo into the uterus. Another reason to remove the fallopian tube would be access factors like the ability of the operating doctor, of the surgeon, to be able to safely make an incision in the tube and remove the ectopic and leave the tube. There could be bleeding, there could be visibility issues, there could be other technical issues making doing a salpingostomy more difficult. Also, if the patient is hemodynamically unstable, that means the ectopic has ruptured, there is a lot of bleeding, maybe a blood transfusion is being considered, then removing the fallopian tube completely would be a better option for the patient.
The third option when it comes to treatment or when we're discussing treatment topics is expectant management. Expectant management basically means watchful waiting. In some cases, where the beta HCG levels, let's say, are quite low already, or they're already starting to decline naturally, close observation can be an option. But this means that you need to have a really good relationship with your care team. You have to be somebody who is able to come in for very regular and very frequent blood work and ultrasounds, somebody who can go to the emergency room quickly if they need to, if they're experiencing symptoms, and that you thoroughly understand the potential risks. Because this approach is a bit more risky and really does require, as I said, that close monitoring, careful monitoring. The fallopian tube is not the ideal place for a pregnancy to grow. And so pregnancies do miscarry more frequently when they're in the tube than in the uterus. And so sometimes this is referred to as a tubal abortion, as opposed to a spontaneous abortion, which is often a term used to describe miscarriages. But certainly that can be an option for some patients in certain situations.
Now, every single one of my fertility patients who has had an ectopic pregnancy has one very important question for us. And that would be, now what? Can I get pregnant again after having an ectopic pregnancy, regardless of what treatment we use, surgical, medical, or expectant management?
Yeah, that's so right. It's the number one question for sure. And the really good news is that the vast majority of patients who've had a previous ectopic pregnancy can succeed at having a live birth spontaneously, especially if the tube is left in place and if it's open, or with IVF and an embryo transfer if the tubes are not functional, if they're blocked or if they've been removed. But certainly pregnancy rates are excellent after ectopic pregnancies.
Now, this is not just us being our usual positive, peppy sisters. There's actually a study that shows this. So, this was a study that looked at 228 women after having an ectopic pregnancy, and it was published in Reproductive Biology and Endocrinology in the year 2020. What they found is the study was looking at the reproductive outcomes after having a tubal ectopic pregnancy that was treated using any of the approaches that we discussed before. They found that the cumulative intrauterine pregnancy rates after an ectopic pregnancy were 70% for people that had expectant management, 83% for people that had methotrexate, and 100% for people that had surgical management with salpingostomy or salpingectomy. It is important to mention that the study found that salpingostomy, remember this is when you remove the ectopic but leave the fallopian tube, did achieve a high rate of intrauterine pregnancy, but it did carry a slightly higher risk of recurrent ectopic pregnancy compared to salpingectomy, which is when the fallopian tube is removed.
This study concluded that both medical and surgical treatment of ectopics offer really good fertility outcomes, with medical management being a little bit less invasive, right? Because you're not having surgery. And surgical options, especially like a salpingostomy, where you're preserving the integrity of the tube. But it is really important to note that the choice of treatment should depend on the specific patient's condition, symptoms, social situation, geographic location, the extent of tubal damage, which again, you can't really assess until you're actually in the operating room looking at the tube. And of course, the desire for future fertility.
So that is it for now, superhumans. I hope that you found this episode useful. We talked about what an ectopic pregnancy is, what are the risk factors, what is the management of it, and how to make a diagnosis, and ultimately what happens after an ectopic pregnancy. And the good news is that many, many patients are able to still have a live birth after an ectopic pregnancy.
And that's a wrap for today, superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music by Mixkit. Life is a Dream by Michael Ramirez C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.